Alright, so good morning, and first of all, let me thank the organizers, Dr. Amit and Dr. Pooja, for giving me the opportunity to talk in this instruction course. I will be speaking on surgeries in uveitis and the basics of that. Dr. Rima has already elaborated upon what are the diagnostic indications of vitrectomies in cases of uveitis, and we cannot undermine the importance or the advantage that a vitrectomy affords to us in these cases. Now, we will not go upon these, but the fact is that over a period of time, with the evolution of instruments and evolution of vitrectomy surgery as such, the surgery has become much more safer. From 20 gauge, we have now migrated to 23, 25, and even 27 gauge. And with the 0.5 or 0.4 millimeter entry into the eye with faster cut rates, we have got shorter operating times, faster recovery for our patients, and our techniques have become much more improved, lesser invasive, and afford much more of a manipulation inside the eye. Now, there have been already multiple papers which have shown the importance of a therapeutic vitrectomy in these eyes, where they have shown that removing even the load of antigens helps in regression of cystoid macular edema in many of these cases. But apart from these facts, apart from the fact that a vitrectomy affords to remove the vitreous opacities, gives us a clearer media, reduces the antigen load and helps in resolution of macular edema, there are certain other indications over here. And those are some which are very peculiar to uveitic cases. These behave differently from an otherwise idiopathic case. So apparel membranes, detachments, diagnostic dilemmas can all occur in case of uveitis, and these are different to handle. RDs or detachments occur in a lot of cases of ARN and CMV in up to 3/4 of patients, and they can have both arachmatogenous and tractional component. Now, there are certain problems which are peculiar to uveitis cases. You have got a pre-existing retinitis, vitreous adhesions are abnormal and much more thicker. You have got thick ERMs, and you need to handle them with care. So let me just go through a few videos which highlight what are these problems which we face when we encounter these things. So, the videos are not playing. What's happening? Yeah. I think I will directly come to the videos, and that will save the time over here instead of this PowerPoint. There's something stuck with the video. So if you look at it, these eyes have got extensively thickened vitreous adhesions in the periphery, and if you look at all of those, these vitreous adhesions need to be tackled. Somehow the characteristics of vitreous in eyes with uveitis is much more different than what you see in a routine eye. This vitreous is much more thicker, there are a lot of opacities. It's probably got to do with more of interleukin expression over here. The ERMs are also extremely thickly adherent, and if you're not very careful, you'll end up causing a break. So you have to be very careful in removing these ERMs. Some of the ERMs, specifically in eyes with acute retinal necrosis or post a CMV or post a retinitis, even in eyes with toxo, we have seen these ERMs can be very thickly adherent, and you have to carefully remove them. Sometimes you might even need to truncate these ERMs. So you can use a scissor or a forceps to remove them. I'm sorry. So this was a thick ERM which we first of all removed after removing the hyaloid, and you can see it's so thick that I had to use a cutter over here to remove it. Apart from that, one more problem which you face is the peripheral necrotic retina. The retina in these cases is totally necrotic. You will see these multiple areas of or patches of necrosis and peripheral breaks, and these are the areas from which the detachment occurs. So you have to be careful while even you're doing a vitrectomy. If you try to induce a PVD or try to pull too much, you will end up creating more of breaks than what you otherwise would be hoping for. So be careful about the peripheral necrotic retina which you see over here, because that is something which you need to handle. You can truncate or shave your vitreous over here instead of doing anything else. When it comes to doing a laser in these cases, that is another problem. The fact is that your laser has to be done in eyes which in the area of healthy retina. And again, just I will like to highlight one more video of an ERM. So this is, again, was a patient with an extremely thick ERM. If you see over here, you have to be very gentle. Otherwise, what you'll do is you'll end up creating a break or even a macular hole. So the point over here is that in cases where you've got a surgical intervention, in cases of uveitis, you have to handle the vitreous a bit differently from what you as a retinal surgeon will do for routine cases. So these are the cases. This was how this patient was initially, and I'll just switch on back to the PPT. So this was how the vitreous was, and this was how the patient's eye was pre-operatively, and after you remove, the ERM settles down, the visual acuity also improves. So in conclusion, detachment surgeries in cases of viral retinitis are different. Vitreous adhesions, necrotic retina, and thick membranes need to be addressed properly. There is also a high risk of recurrences, and these eyes will require a long-term tamponade. So in the interest of time, I'll stop, and I would at this point of time also like to invite you for the next Uveitis Society of India conference in Hyderabad from 9th to 11th of October. Once again, thank you for being here early morning, and thanks to the organizers of this IC. Thanks a lot.
Thank you, Dr. Tyagi. Any questions?
My question to Dr. Reema. Ma'am, these days are you doing just purely vitreous biopsy using the doing vitrectomy, or like earlier we used to do vitreous biopsies with a 26 gauge needle in the OPD or emergencies? Is that indicated anymore?
No, I think, Pooja, in the era of microincision vitreous surgery, just the vitreous aspiration is not recommended. We don't do it. So we simply just go for a good vitrectomy that helps for both diagnostic and therapeutic. So just aspirating, no, I think it has more of complications.
Thank you, Dr. Mudit. I thank the audience for a patient hearing. Thank you. Can we have a photograph?
इसको लगा दीजिए.